Hi, thanks for joining us. This session is regarding Cushing's disease. I'm the president of the Cushing Support and Research Foundation, which is a United States-based nonprofit patient advocacy group. My name is Leslie Edwin. I am joined by Dr. Elena Valassi from Barcelona, Spain, who's going to start our conversation about patient registries and other things, but she's got a lot of good information about Cushing, which is the European Cushing's registry, and then I will follow up with some information from my organization. So, Dr. Elena Valassi.
Good afternoon, and thank you, Leslie, for inviting me. I'm delighted to be here. I will talk a little bit about the experience of the European Registry on Cushing syndrome and why registries are so important for patients as well. So this is a registry which started in 2008. It's owned by the European Society of Endocrinology, and currently it contains more than 2,000 patients from 56 centers in 29 countries. Cushing was originally aimed, and still has this aim, to gather data at the European level on epidemiology, comorbidities, diagnosis, therapy, quality of life, and mortality. So there are many goals in the Cushing, but certainly the most important ones are try to identify the reasons for delay in diagnosis of Cushing syndrome, which, as we know very well, it's an important paramount issue, we could say, in rare disease. So actually the registries can help to improve awareness of this rare disease among communities, but especially among health specialists. So other goals of the Cushing are to define endpoints of treatment, also including quality of life and patient-related outcomes, analyze regional differences, and also create a network to improve information, patient empowerment, and, as I said before, awareness of the disease. So according to the Cushing data, median delay in diagnosis was 2 years overall, of course, in a patient with ectopic source of CTH, ectopic Cushing, of course. The delay was shorter due to the more severe presentation in them, but 2 years is an important period of time, and many other studies also demonstrated that can be even larger, up to 3 or 4 years, as a median, of course. Indeed, patients face with a very long journey, so talking and seeing a lot of specialists who often missed the correct diagnosis. In particular, they see the general practitioner. Actually, the general practitioner is on the front line of the diagnosis of and recognize this condition, but also diabetologists, which could be internists, internal medicine specialists, not necessarily endocrinologists, gynecologists, of course, psychiatrists, rheumatologists, and dermatologists. So why it's so important to try to shorten the delay to diagnosis? Because it has been demonstrated that some psychological and emotional morbidity can persist long-term even after remission is reached. And this this psychological impairment, which persists in the long term, is associated with the duration of the exposure to cortisol previously during the active phase of the disease. So, of course, it seems reasonable and almost obvious, I would say, that to shorten the exposure to cortisol excess reduce the impact of the morbidity when eucortisolism is reached, not only during the active phase, and can accelerate the recovery, physical and psychological recovery of the patients. Actually, patients with Cushing syndrome in remission had significantly lower quality of life measures as compared with healthy controls, and actually quality of life was not restored after a median of 72 months in this study, especially because they also had anxiety, depression, more negative affect, impaired affective balance, elevated perceived stress. And most of these measures, as I said before, were associated with the delay in diagnosis, so the duration of time elapsed to reach the correct diagnosis. Okay. And this was confirmed recently by, in a very interesting paper showing that use of psychotropic drugs remains elevated long-term after treatment. As we can see here from this graph, use of anxiolytics decrease within 5 years of remission of treatment of Cushing, but is not significantly different as compared with baseline. After 10 years, yes, use of anxiolytic is significantly reduced, probably because patients are in the meanwhile learning to cope with the situation and try to adapt to the post-Cushing situation, although we know that it's very difficult as well, and they should be properly helped to reach this level of disequilibrium, we could say, and to try to find a new equilibrium. But for example, painkillers, the use of painkillers remain significantly elevated in the long term. So we should consider also the physical morbidity in this patient, especially related to bone and musculoskeletal system. Actually, these are data precisely from the Ercusin, showing that a patient with pituitary-dependent Cushing, even 1 year after surgery, and 93% of them were cured or were in remission, had some alteration, impairment of some parameters of the Cushing-Qual questionnaire, in terms especially of pain, wound healing, and physical appearance. And the total Cushing-Qual score was not different in these patients as compared with the active phase. So this means, again, that recovery of quality of life is not immediate, but certainly require more time to be almost normal, we could say. And then in adrenal, this was observed especially in pituitary-dependent Cushing, more than in patients with adrenal-dependent Cushing, probably because we know very well there are some other morbidities associated with pituitary-dependent Cushing, for example, hypopituitarism. And then when the same patient were observed after a median of 38 months, so again, in this case, we can see that other items of the Cushing-Qual, such as leisure time, memory, worries on future health, were significantly more impaired in pituitary-dependent Cushing as compared with adrenal Cushing. And also the total score was significantly lower in the former. But when patients were analyzed together, we'll see, in order to identify possible predictors of quality of life in the long term, depression at baseline was the most significant predictor, together with remission, of course. So the importance of recognize depression earlier in order to reduce the impact of depression itself on the long-term morbidity and on quality of life. And this, of course, affect the working status, of course. In 347 Ercusin patients, we could say that 34% of them were on disability pensions 10 years after surgery. So we could say that at the diagnosis, 23% of them were not working. So definitely this also lead to an important socioeconomical burden. And even if it's a rare disease, probably healthcare representatives should think about that, because it's a common feature observed in other rare diseases. And this is the voice of patients. So patients actually coherently, in accordance with what we have just said, experience more working problems, leading to, again, contributing to impaired quality of life, and, as I said before, the socioeconomic burden. They have various types of difficulties, like physical demands, especially patients who work physically, we could say, in order to also patients who had the responsibility for scheduling, for example, or intellectual works, because they experience memory problems, planning problems, and so it's difficult to maintain concentration, it's difficult to maintain attention, not only in the active phase, but also long term, as I said before, after remission. So it's important to recognize the residual morbidity, the residual cognitive problems in these patients. And actually, they feel that they need support, and they ask for support. And the preferred supportive offers were in terms of webinar, online forum. Also, they would like to receive in-person support group or participate in in-person support group, and also courses, some educational programs to cope with the illness. And the topic of interest, according to these surveys, which was published in 2018, were a communication with other people, nutritional advice. They would like to receive education on how to manage stress. Physical activity is important, and they don't know how to develop a physical activity. They would like a personalized, probably plan, because, of course, they experience pain. We should not forget the problem of osteoporosis and the problems of non-traumatic vertebral fractures, which affect most of the patients and keep affecting them even long-term after hormone cure. And of course, according to the socioeconomic burden we told before, they also had, they would like to receive support in terms of some financial issues. And it's important, I think it's fundamental to recognize that there is a different perception of remission between patients and physicians, of course. So as we can see here in this graph, so in this study it was shown that 65% of patients who are in biochemical remission feel that they were not. So in this survey, patients were not were asked to express their feeling about their state, and they didn't know if they had actually normal hormones or not. So they placed themselves in the category of not in remission because they didn't feel good. But of course, the physician was very happy with them because their hormones were normal. And these are some of the aspects which, according to the patient, are more bothersome for them. Of course, they suffer from a difference, a change in their physical appearance and body image, which of course impact on the emotional processing and on the social dimension of quality of life. They also had, as I said before, neuropsychological impairment. They are well aware of that, and they suffer for that. And also muscle weakness and low energy is one of the most important issues and one of the most important complaints, which often remain unaddressed. And then, again, delay to diagnosis. So patients are still very, we could say, annoyed somehow of the delay to diagnosis they experience during the active phase of the disease. So although they maybe they don't think that this could have impacted the morbidity, the residual morbidity they feel after remission, they certainly keep thinking of the way they were treated before when many doctors did not believe in what they said. And so this also contributed to increase frustration feeling, persisting frustration feeling. And so, of course, it's important to identify what are the needs of these patients, the unmet needs, and try to meet these needs. So in this focus study from the Leiden group, some psychological and social aspects have been identified. So among psychological needs, there is fear of recurrence, panic, persisting thoughts, problems with a changed personality. And in terms of social issues, patients declare to have a reduced social network. They have difficulties in communication about the disease, and they feel that there is a lack of sympathy of the environment, for example, at work. So all these, of course, negatively impact on quality of life and produce a kind of vicious circle, because, of course, if they experience this emotional and stressful condition, they cannot elaborate coping strategies efficient enough to cope with the situation. The perception of the illness keep being very negative. They also, for the frustration we mentioned before, develop negative beliefs about medicine, especially this is important nowadays in the social network era, because they could believe in everything, maybe, some of them, not all, but it's threatening. And as I said before, the vicious circle generates new unmet needs regarding care, and these needs are not properly addressed and generate, in turn, new needs. So according to this group, so there are 5 important unmet needs that they try to address through an educational program. So stress management, so to learn how to manage stress is important for this patient. To practice physiotherapy, just because we have said before that low energy and inactivity and pain, it's one of the most invalidating problems for them. And then receive education about the proper education, sport recommendation, again, like physiotherapy, and psychological care, of course. And these, of course, will if they could receive this kind of support, they could demonstrate and could develop a self-efficacy improvement leading to adaptation strategy. Because what is really important is to understand that maybe it's not possible to go back to the way you were before, but certainly you can still enjoy life, learning to adapt yourself to the new situation. But of course, you should receive help to do so. And it's normal to ask for help, but you should be able to find this help, and sometimes it's difficult to find it. So, for example, again, the same group developed a self-efficacy program and targeting, in particular, psychosocial issues. So they organized the session, like 8 weekly session of 90 minutes, and 24% of patients, the participating patient, had Cushing disease, and the other one had other kind of pituitary disease. And the results were very good because the patients were asked to choose, we could say, choose the issues, the topics which were more important for, which were the most important for them. And in particular, they chose self-monitoring, how to promote health, how to manage stress again, and how to search for social support. So the results were very good because perceived bother by mood problems decreased at the end of the program, but unfortunately returned to normal thereafter. So this means that they need a reinforcement. So it's important not to leave them alone once they have obtained a good results. So probably a second phase should be developed in order to, as I said before, taking advantage of the fact that self-efficacy has increased, probably this should be further strengthened, for example, through the social networks or with any other kind of distance support. But so they could develop higher self-efficacy at the end of each session, not only at the end of the program, at the end of each session. And this persisted after 6 months. But quality of life was unchanged, so the struggle to improve quality of life was still on, probably because it's a multidimensional parameter. Of course, it's not only one parameter, so we should act on different points, on different aspects. But it's positive that they, at the end of the program, asked for new knowledge, new information, new support groups. So there was a proactive attitude in them, and this was considered, of course, reassuring and actually a very good results of the program. Again, this paper has been published last year, it's very recent, and again, emphasize the different perception of health and remission between patients and physicians. Even in the definition of cure, so for a physician, cure is when hormones normalize, but patients, of course, don't think the same. They think that cure is when they feel good, when they say, I can lead a normal life without pain. So again, the topic of pain or musculoskeletal affectation. And then the doctor seems to underestimate the time to complete post-operative recovery. So they often encourage patients to go out with friends, to try to rescue the previous life. But maybe in that phase, patients are more comfortable staying home with family and friends and try to somehow recollect in tranquility and don't force a recovery which in that moment probably their body is not able to endure. And then also, physician probably overestimates the benefits of work, exercise, and activity, because it's another side of what I have just said. Probably in that moment, they cannot, go back to do the same physical exercise they did before. Actually, it's somehow worrisome that only 1/3 of patients considered to have received sufficient information on the post-surgical experience. So they thought that everything will go back to normal after cure and normalization. So in conclusion, prolonged exposure to excessive cortisol is associated with long-lasting complications, which may lead to persisting deterioration of quality of life and a significant socioeconomic burden. To shorten delaying diagnosis is paramount, of course. Registry may contribute to raise awareness and improve management of Cushing, encouraging healthcare providers to compare, identify, and adopt best practices for their patients. Registry may also be regarded by the patient as a reliable source of updated information on many clinical aspects of their condition and may contribute to improve the patient-physician relationship. And now, I think it's the turn of Leslie, who will talk about the patient perspective.
So again, that's me. I was diagnosed in 2012 with Cushing's. I waited till I was florid, so it still took another 6 to 9 months of testing. This is what I looked like a couple of months before I went to surgery the first time, so it did get a little worse, but I stopped taking pictures right about this point. So we're talking about patient registries, but Dr. Valassi touched on some of the reasons why we feel like it's important to have something a little extra than just clinical data registries right now, which there is some institutional registries, in each institution, but there's no US patient registry or even a global registry. And we see our Cushing kind of like a big sister that we look up to and want to be like when we grow up. Because it's already producing such great information that a lot of our patients that we talk to through CSRF reference. And it seems like there's some space for us as a patient organization with the resources that are available to a nonprofit to create a registry. When we look at the existing data, I mean, we formed a patient committee ahead of this meeting to get some input. I didn't want to just do this unilaterally. I wanted to have a group of patients and discuss what we wanted to share with you today. So when we look at the existing data and research, these are literally quotes that came from those calls. I wish I'd known all of this before surgery. I've been suffering for years. I had no idea that this was part of recovery. Finally, an answer for something that's been bothering me. No one seems to understand. But also, this doesn't really answer all my questions. And, well, what about fill in the blank? And I really wish I would have had a peer brother or sister who already went through this to guide me. And that's something, that last one, I think that would be easy for us as this nonprofit patient advocacy group to do. But I put a little onto the side one of the pieces of research that is most popular as far as I can tell amongst patients, because it hits us all. Almost all of us have really painful legs after surgery, even if we're cured or in remission. It just hurts. It contributes to lower activity levels, probably contributes to worse CV. I mean, there's all sorts of reasons, but hips to knee especially hurts really bad. And then all of a sudden, Dr. Valassi and her team come up with this research, and a lot of us were like, oh my God, you know, like this is possibly something that's really going to change my life, and it's about fat infiltration of thigh muscle even after remission of Cushing syndrome. One of the people on our committee is an athlete, and when I had sent out an email seeing if anybody wanted to join the committee, and I referenced this paper, she was like, oh my God, like I just printed that out and I'm going to see my doctor because I'm unable to return to my level of activity and I just can't tell why. And then I read this article and I cried. I probably cried too when I read it. So things like that, like we want to participate in that. That's another reason why we want to create a registry. But a new type, I kind of see it as like a supplemental registry. We're not trying to reinvent the wheel. There's already good ways to collect clinical data. It's just the other stuff, things that are important to patients that the other patients talk about. Maybe we don't feel like we have the time or that we're not heard when we go to the doctor. But it's really good stuff. We did a couple of questionnaires a couple of years ago, and the information from that was really important to patients to see themselves and know that, okay, I'm not the only one. 140 other patients, you know, said they experienced this thing too. That we just did a simple questionnaire, and it was actually picked up by some researchers at Johns Hopkins, and they wrote an article about it. They did some scientific data stuff and turned it into something professional. And so that's in the process of getting published right now, which is very exciting, because we kind of just made that for us and to show doctors. So what we're proposing is a patient-led registry. It will have verified enrollments to make sure that the data that comes out of it is verified to be from literal Cushing's patients. But we're going to develop the surveys. We'll have space for the other ones too. We'll have some standard ones, and we'll always be open to anybody who has questions or wants to ask our organization, our members, something. We'll be able to do that too, but we have lots of ideas as well. So this is kind of our venue to do that. It's active, ongoing patient engagement, because sometimes people will sign up for membership and then they're like, what can I do to help? And so other than administrative jobs and creating things, like this is one of the ways, is to come up with what can we create to share with professionals from our voice that's different than what's already out there, or supportive or new. It's a peer support. I mean, we're gathering together, talking about our problems, I mean, and trying to find solutions for it. There's two different registries that we're looking at right now, platforms, and both of them allow a patient, once they've answered a questionnaire, in real time to just go back, okay, now show me what the results are, de-identified, of course, for everybody else in this registry, because I want to compare myself to it and see if, you know, on this data point, there seems to be, you know, is it just me or is it all of us, basically? We're able to get into more specific quality of life details, I think, than what's in clinical registries right now. And also our doctors who do not have the time to go through IRB and legal department and all of that just to get a questionnaire out. They can just email me and say, we're wondering about this thing, and we would be able to do that. As a patient group, we have like some flexibility, I think, that doctors maybe don't. And it will have a medical advisory committee. No way we could do it without that. But the biggest thing I feel like is just validation. You know, I was diagnosed 10 years ago, and there's still things right now that are the exact same way, and I wouldn't have guessed that. This is our opportunity to change the story for patients now and in the future, and validate our experience now. Why bother? I heard that question from one of our medical advisory board members, but I'm not going to tell you which one. The point was, well, you're just a little patient advisory, patient group. Why don't you just stick to those patients? Why don't you just, have some support groups and stuff? I can't think of a better way to support patients than to create new data for all of you to see and to know what's going on with us. So that's why bother. Here's another reason. I love this graphic. Misinformation and biased opinions online. I mean, that's one of the hugest road bumps, in my opinion, now to getting a correct diagnosis and understanding what Cushing's means in the first place. And I don't know if everyone in this room watches The Simpsons. This is Nelson. He is Googling what I want to be true. I'm a researcher. So unfortunately, with a nonspecific endocrine disease, this is what happens a lot of the time. And you will find a Facebook group that will tell you that you have Cushing's before you've ever been to a single doctor. So this is something that's infuriating to me as a human person, and it's one of the things that I want to create this registry, and one of the things I just want for my community to have. This is a lot of words right here. I'm going to just try to skip it. I will be in the patient experience zone, and I'm going to have all of this on a constant repeat on our screen. So if you would like to see some more of the data, I'm going to just go through it really fast. But we had 175 respondents. We formed a committee last month. I sent out the survey on Monday. So in 48 hours, we had 175 people out of 2,000 respond to this kind of long survey. That's almost a 10% response rate. I feel like that's pretty good. So most of the data reflects the averages that you can probably find in research. I'm not going to go through it, but mostly pituitary, mostly women. Most of us are in recurrence. Most of us are from the United States, but we do have a lot of patients from Canada and Australia, and that was also reflected on here. When I say patients, I mean members. And again, with the tiny print, I will not read all of this off to you. You can come to our patient experience zone and see it and talk to me yourself. But some of the things that stood out to me, like we had one really long question. It was like, do you experience these things, yes or no? And then, so that's what this came from. Almost all of us believe that this is a disease where you must get very sick before it can be diagnosed and treated. We also believe that validating our patient experience is one of the most important things that you can do for us. Just because our blood results fall into normal ranges, that doesn't mean my symptoms are gone or that I'm okay. The classic Cushing's image, which is the huge gut and, and all the problems, super helpful because I saw myself in it. But then at the same time, a whole bunch of people were like, that's super harmful because I didn't look like that. And my doctor told me I couldn't have Cushing's because I wasn't overweight, I didn't have the striae, didn't have the hump, didn't have the round face. And that is harmful and not true. Most of us do have some element of that physically, but not all of us. And healing is a slow process and does not only include the normalization of cortisol, of course. Let's see. So under the emotional, psychological, I was told I would be all better and back to work about 6 weeks after surgery. Almost half of us said that. In America, if you're sick, you probably get about 6 weeks of paid or unpaid leave, and then you got to get back. Same with being pregnant. We do not have some of the social, safety nets that everyone else in the world has. So that's probably, I think that's where the 6 weeks thing comes from. And a lot of people struggle to try to meet that because they have to get back to paying their bills, or else they're going to lose their job. So it's really difficult to try to cram all of that recovery into 6 weeks. It's basically impossible. I've been diagnosed with PTSD, about 10%, but I believe I have PTSD is about a third. I still find so many things stressful and it's difficult to cope. It's over half of us. I feel that my health problems are all-consuming, half of us. Ongoing pain, half. Problems with stamina, most. I've recovered pretty much back to my old normal. It's like a third of us. I just missed long-term memory problems because I have a memory problem. 2/3 of us. I mean, it just doesn't stop. It's amazing how many problems that you can have just from this one disease. One little tumor up there, and yet I can't ever get back to normal. I can't walk more than 2 or 3 kilometers without feeling like I'm dying. It just doesn't go away. And so this is where a lot of the validation and peer support, I think, comes in, because like Dr. Valassi said, you know, in the biochemical remission, okay, all your numbers look good, good, you're out the door, but it's just not that easy. So a few more other data points from our research was, if you had any of the following autoimmune disorders that were unmasked once your cortisol was resolved or as a result of Cushing's, Addison's, arthritis, chronic fatigue syndrome, fibromyalgia, and then a list of other ones I can't even pronounce. But fatigue, fibromyalgia, arthritis, pain, exhaustion. That is our motto, pain and exhaustion. And then how was your employment affected by Cushing's? I think this, it complements the data that came from Cushing, but it's also reflective of our situation in the United States. Almost half of everybody was able to go back to work full-time, probably because they had to. 20% had to work reduced hours. Almost 15% had to change jobs. I mean, that's your identity sometimes. If you've been working the same industry or career, and all of a sudden you just can't, but you have to keep working because you still have bills to pay. It can be very jarring to have to just completely change course, especially when you're 40, 50, which is kind of the average age when people start getting diagnosed with Cushing's. And then a little over 20% weren't even able to return to work. So I guess I will just leave you with my thought, which is that probably besides validation, one of the really great things that you can do for your patients is to realize that they're going to need referrals to other specialists once they're resolved, you know, once they're cured, because there's going to be long-term problems. They might have pain, they need to go to a rheumatologist. They might have problems with their stomach and digestion, they need to go to gastroenterology. They might have problems getting back to exercise, send them to physical therapy. They might be depressed, they need to go to a psychologist or a therapist, because we know that the endocrinologist is not our catch-all doctor, but a lot of American patients anyway feel that once this biochemical remission is achieved, that we're just sort of set free and don't know how else to get these referrals, or some people just suffer in silence. I know that I suffer in silence a lot because I'm sick of being in the hospital, sick of doctors, not you guys, all the other ones. And it just gets tiring and it's expensive. So sometimes we're just like, just screw it, I'm just gonna just live with this. But that's not necessary, it's contributing to a lowered quality of life. So a really great thing you could do would be to refer them to the people who can help them with the things that they continue to complain about when you see them for follow-ups. So we will, I don't know that we have a lot of time for questions, but if anybody has any questions, please feel free. Sheila? What do I do? Do I stand up? Shout. Shout. Or, I mean, there's a microphone.
Okay, I have a question regarding PTSD and Cushing's. So this is the first time, so I'm not a Cushing patient, I'm an acromegaly patient. And as far as I'm concerned, I have never been diagnosed with PTSD. Is this something that is diagnosed in the US? Because I have never heard of it in Europe, and maybe that was before when I was diagnosed a few years ago.
Yeah. So is post-traumatic stress disorder a thing?
Yeah.
All right. I think just different communities, I guess, might be more aware of it than others. I think there's a lot of times when people will hear that a patient, like in our patient committees and groups, you know, somebody will say, I was diagnosed with PTSD, and literally everybody's like, I never thought about that, but I'll bet I have it because I just can't get past this, and things will trigger me, and I get sick, and I know it's back, you know, it's just, you just can't get out of that Cushing's cycle, and I guess maybe acromegaly is probably the same way. It's just like anytime something happens. So I wouldn't say it's super common, but we try to talk about it as much as possible because it's a real diagnosis and you can get help for it. And also if you say PTSD, unfortunately, if you say, I have a brain tumor and it causes my body to do all these things, you'll get a glassy stare. But if you're like, I have PTSD, oh no, are you okay? You know, people will understand that better sometimes, and people just like your family and things, especially if your disease is invisible. Yeah.
Maybe if I may add something, traditionally, in the past, not now, but in the past, probably in the US, there was more awareness of post-traumatic stress disorder and more research in the past due to the veterans and because it's a very frequent disease in war veterans. But in Europe now, there are many studies about this in several conditions, and I think that interesting data will go out soon about this, because especially in Cushing, the mechanism implicated in the development of some of the typical psychological features in these patients are quite similar to post-traumatic stress disorder. So there is a very similar profile. So considering that cortisol acts on the same receptors in brain and the same mechanisms involved, the mechanisms involved are the same. So it seems that post-traumatic stress disorder is much more frequent than previously thought in patients with Cushing, and in another important aspect of the emotional spectrum in this condition.
If you think of a question, I'll be in the patient experience zone. Thank you for attending this session. Really appreciate it.
I just only one question for you. So have you noticed in the last years somehow an increased attention by physicians in terms of the residual morbidity? Because in the past maybe there was no that sensitivity, no? But now probably the awareness is increasing. And what is the opinion of the members of the association? They think that now there is a more attention about these problems, the persisting morbidity, or not? Have you noted a trend over the years?
I notice a trend because I don't stop talking about it myself. There does seem to be a trend because the organization is growing at a higher rate than normal. Unfortunately, those Facebook groups that I was vilifying earlier do increase awareness of Cushing's. You know, and people look for a symptom and then they go online and can find a group about it. I mean, in a way, I guess that's good. But there does seem to be more awareness. There seems to be more research. Cushing helps with that. Yeah, I would say in 10 years at least, there does seem to be more accessibility than there was when I first started looking 10 years ago. Still a lot of work to do.
Yeah, of course. And another question. So the new patient-reported outcome questionnaires that you are trying to set up, so what do you think that there are the most important issues that should be included?
We don't have time to get into that.
Yes, just...
I would say the long-term quality of life issues that don't go away, that we end up sweeping under the rug because we're just, like our doctors seem to, well, but you're cured or you're in remission, that get the least amount of attention and yet bother us the most because we can't fix it ourselves. For example, the leg pain, problems with insomnia, problems just lowering anxiety. Not everybody wants to take 4 pills for anxiety. So like Dr. Gear at Memorial Sloan Kettering and her team have started working with integrative medicine, integrative health. They've got someone on board now who talks about acupuncture and meditation, other non-surgical, non-chemical ways to handle stress. I think that we have a lack of good stress management self-tools. We just take a pill. Yeah. And there's a lot more to it than that. So I think looking more into that. And then, there's lots of things, but that's a good one.
Would you like to introduce also questionnaires or patient-related outcomes questionnaires in the database? Do you think that it's useful to try to, put the results of the questionnaire. So pass the questionnaire to the patients, and then quality of life questionnaires, for example, or what kinds of questionnaires?
Every time we do a questionnaire, the second they finish it, they'll email me, can I see the results when it's done? So we do share that. We're updating our website, so we will be adding a section for the results of these, especially once the registry is built. We're gonna need a whole section just for the types of reports, because we'll be making posters and we'll be making white papers. We'll be soliciting research students to turn these things into papers and things. So yes, that will become more robust over time as it builds out.
Okay, thank you.
Thank you.
Okay, I think the
that's it.
session is finished.
I think that's it.
Thank
We
you.
went way over time. Thanks for listening.